This will be going over the respiratory system. The function of the respiratory system is to obtain your oxygen needed for cellular metabolism and to eliminate carbon dioxide and other waste products produced by cellular metabolism. Respiration, which is carbon dioxide and oxygen exchanging across the cellular membrane. This is broken down into internal and external respiration. So external respiration, this happens at the capillaries around the pulmonary area between the outside world and the lungs. Now, internal respiration is where this gas exchange happens inside the body at the cellular level. And then ventilation is just the mechanical process of moving air in and out of the lungs. And in order to understand how the gas exchange occurs in the body, you need to understand a little bit about your gases so that you know how they work in the body. So we know that the atmosphere around the Earth is a mixture of different gases, and each gas within that mixture is going to kind of put a certain amount of pressure that contributes to a total pressure. Probably the most familiar example you would know of this is like barometric pressure that they talk about with weather. When we are talking about pressures, we are often concerned with an individual pressure or individual gas that contributes towards the total pressure. So we're going to refer to this as partial pressure of whatever gas is. So that would be represented as PA. So if you see PaO2, that just means partial pressure of oxygen. Okay? The air we breathe in, 79% nitrogen, approximately 21% oxygen, and some other trace gases there. With the atmosphere being 21% oxygen, it contributes 21% to the total pressure of the atmosphere. Now, as air enters the alveoli upon inspiration, it mixes with stuff that's already in the alveoli, mostly water vapor and carbon dioxide. So the partial pressure of oxygen in the alveoli is 100 millimeters of mercury. It's measured in millimeters of mercury. Not all the oxygen that you breathe in is going to be able to cross the respiratory membrane. And we only use about a quarter of the oxygen that we inspire. So expired air contains about 16% oxygen. This is why for a long time with CPR they taught you to do mouth to mouth, because 16% of oxygen is still a lot better than 0% oxygen. Now, it's important to understand the differences in these pressures of partial pressures of carbon dioxide and oxygen, because that's what's going to determine the direction that they diffuse. Remember, diffusion is moving from one area to another. Gases are going to diffuse along a gradient from an area of higher pressure to lower pressure, so they're going to try to diffuse out. All right. Picture, if you will, that they are just kind of dissolved and floating around in the bloodstream so they can be transported to wherever they need to go. Okay, so we've got oxygen molecules that are coming in. Most of that is going to be bound to hemoglobin, and we know hemoglobin is that protein on the red blood cells. About 98.5% is bound there, and the rest is dissolved in the plasma. Carbon dioxide is carried three different ways, predominantly, and most of it is going to be in the form of bicarbonate. Some of it's going to be bound to hemoglobin, and then a small amount is going to be dissolved in. Oxygen is used at the cellular level, which means that the amount of oxygen in the blood that comes back to the heart is going to be low, because you're using it up. It's getting used at the cellular level, so when it comes back, that level is a little bit lower. This deoxygenated blood is pumped from the heart to the lungs, and when that blood enters the capillaries surrounding the alveoli, this partial pressure is about 40 millimeters of mercury. Remember, it was about 100 millimeters of mercury when it came in. So it's made its circuit around the body, and now it is about 40 millimeters of mercury. As the oxygen diffuses from the alveoli that you've breathed in to the capillaries, the partial pressure of that blood increases again back up to about 100 millimeters of mercury. The PaCO2, or partial pressure of carbon dioxide of blood returning to the body, from the body to the heart, is going to be 45 millimeters of mercury. The level decreases to about 40 millimeters of mercury as carbon dioxide diffuses from the bloodstream to the alveoli to be exhaled. So remember, with diffusion, they're going from higher pressure to lower pressure. So those partial pressures are real important as determining on which way that carbon dioxide and oxygen are moving. Now, the amount of oxygen that can bind to hemoglobin and how well it can be released at the cellular level, which is where it needs to be released, depends on quite a few things. One of the most important factors is that partial pressure of O2. When that PaO2 is higher, more oxygen can be carried by hemoglobin. The higher the PO2, each hemoglobin can be more saturated with oxygen. The more saturated it is, the more oxygen it can deliver to the cells. At the cellular level, where the PaO2 is a little bit lower because it's getting used, oxygen is released more readily to the cells. So this relationship between that hemoglobin saturation and the partial pressures of oxygen is called the oxyhemoglobin dissociation curve. And I have linked a video in the course to a YouTube video that's really a great presentation on the oxyhemoglobin dissociation curve. Boyle's law is one of the laws that you need to be familiar with as far as gas pressures go. And what this does is it states that the pressure of a fixed quantity of gas varies inversely with its volume. So what this means is the same amount of gas will be under less pressure if the container is larger, and will be under greater pressure if the container becomes smaller. It's just like if you were to lose or gain weight. So you take your body and you have one pair of jeans and you eat a bunch and you gain 25 pounds. You try to squeeze into those pair of jeans, that pressure is going to be a lot greater because that container essentially has become smaller. Now, if you lose a bunch of weight, then that pressure is going to be much less because they're going to fall off of you because they don't fit as well anymore. So air is going to move from areas of higher pressure to an area of lower pressure. We have to have movement in the ribs and the diaphragm that's going to help with this movement. So what's going to happen is during inhalation, the thoracic cavity is going to increase in size. So when it increases in size, the amount of air that was in there will become will turn into less pressure. So the pressure relatively in the lungs is lower than atmospheric pressure, which means air is going to come in. Then that thoracic cavity has increased in size, so now it reaches its stretch point, which we'll talk more about in a few moments, and now that thoracic cavity is actually higher pressure than ambient air, so it's going to release air in exhalation to try to equalize out that pressure. Here's just a good little overall picture of the respiratory system there. Now, quick respiratory system anatomy review. We know it's divided up into upper and lower airways. First, we're going to talk about that upper airway. So we know that the upper airway is responsible for warming, humidifying air, filtering out any debris, things like that. Up the top here, we have our nasal turbinates. Right here. And what these are going to do is kind of slow down the air and circulate it around the mucous membranes that line that nasopharynx in order to warm it and humidify it. You also have little hair-like projections or cilia of the epithelial cells that are going to help kind of cling to any dirt and debris and filter out anything to keep it from getting into our lungs. Next, we have the oral cavity. This is our teeth and our tongue, and it is continuous with the posterior oropharynx. The base of that tongue meets down at the epiglottis, which is the angle of which is called the vallecula. Below that you have your laryngopharynx, and what this is the final common pathway for food and air. So this is where they part ways. This ends at the opening to the esophagus and to the larynx. The epiglottis is this flap of tissue that covers the opening of the larynx whenever you swallow so that we don't aspirate food into the lungs. Our lower airway begins with the larynx, or sometimes called the voice box. It is anterior to the esophagus, and the thyroid cartilage covers part of the front side of it. The vocal cords are actually within the larynx itself, and the opening between those vocal cords is called the glottis, or you may hear it referred to as the glottic opening sometimes. The larynx is continuous with the trachea, and it's just a pipe. It's got C-shaped cartilage rings, and depending on how tall they are and the length of their trachea determines how many rings they actually have. The very first ring, which is the one that we're most concerned with, is the only complete ring, and that one's called the cricoid cartilage, and you recognize that from palpation on somebody's throat. Now, going on down, you've got your trachea divides or bifurcates into the left and right mainstem bronchi at the carina. The right mainstem, or primary bronchus, is wider and follows a straighter path off of the trachea versus the left, because it is making room for the heart. The left side has to branch out a little more severely due to the heart taking up some space there. So because of this, the right main stem is more susceptible to intubation, and it's also more susceptible to foreign body aspiration. Now these bronchi keep on dividing quite a few times, and they get smaller and smaller until eventually they terminate in the tiny bronchioles that lead to the alveolar ducts and ultimately the alveoli. Within our lungs, we've got quite a few things that we need to be familiar with here. So we'll start with alveoli. The alveoli are small sacs that are only 1 cell thick, and they are kept open by surfactant, which just kind of holds surface tension on them. Without this, they would collapse. All right, now on the outside of these 1 cell thick alveoli, you have networks of pulmonary capillaries, and these capillaries kind of, if you will, picture it kind of like a spider web maybe over a grape cluster, or it enwraps each individual grape. So these are also 1 cell thick, and they surround this alveoli. So this contact allows the transference of gas such as oxygen and carbon dioxide. This area of contact is called the respiratory membrane. Now you've got approximately 170 alveoli per cubic millimeter of lung tissue. That's an astronomical number of alveoli. So about 300 million, I believe is what the book says, alveoli in each lung. These alveoli collectively are called lung parenchyma, which is just tissue, functional tissue. Each lung is divided up into sections called lobes. The right lung has 3, the left side has 2 because the heart occupies that other space there. These lungs are covered by a thin membrane called visceral pleura, and that folds over itself to form the parietal pleura that lines the interthoracic cavity. And you've got a very small amount of fluid that's secreted in between these 2 layers, which lubricates it and allows for smooth movement between inspiration and expiration. The way this pleura is designed, it allows for one single opening, and that opening is called the hilum. And this is on the medial aspect of each lung, and this is where the bronchus, the bronchial arteries and veins, the pulmonary arteries and veins, the lymphatic vessels all enter and leave the lung area. Ventilation consists of 2 phases, both inspiration and expiration. Inspiration is an active process, so it requires energy. And it will actually begin with the signal from the brain to breathe. This signal originates from your stimulation and chemoreceptors in the respiratory control centers in the medulla oblongata, in the brainstem. That's going to be your primary stimulus to breathe. Now you also have a secondary stimulus to breathe. The primary typically is referred to as the hypercarbic drive, and the secondary stimulus is probably one that is familiar to you, but it's called the hypoxic drive, and we will talk more about that in a few minutes. Now, our respiratory cycles typically occur every 3 to 5 seconds when we're at rest, which equates to 12 to 20-ish breaths per minute. And once again, this just depends on the body's needs. So if bear comes in, you need to run for your life, your respirations are going to increase. If you go run around the building a couple times, your respirations are going to increase. If you're sitting there vegging out watching Netflix, respirations may drop a little bit. It's all just based on your body's needs. So when we're talking chemoreceptors, the carbon dioxide that's produced by your cellular metabolism combines with water, and this is going to create carbonic acid, which is the H2CO3. This is going to dissociate or break down into hydrogen and bicarbonate. Remember, most of your carbon dioxide is transformed or transported in the bloodstream as bicarbonate, and then is transported to the lungs. This increase in hydrogen is going to decrease the pH or make it more acidotic. The chemoreceptors in the medulla sense this increase in carbon dioxide by sensing a decrease in the pH of the blood in the CSF, which stimulates your inspiration. You've got your chemoreceptors there. They measure blood at the aortic arch, and they measure CSF at the brainstem. All right, so when this inspiration occurs, it brings in more oxygen, which is then followed by expiration. And the reaction that creates the bicarbonate is reversible, so it's converted back to carbon dioxide and water when that new oxygen comes in, and so that way carbon dioxide can be eliminated with this expiration. Now the signal itself that comes from the medulla is transmitted by your nerve tracts down to the spinal cord, and they exit through the phrenic nerve, which originates at C3, 4, and 5. If you ever heard the term C3 through 5 to stay alive, it's because if you have a cervical fracture at those areas, you could actually damage the phrenic nerve, which would then terminate the ability to breathe spontaneously. So this phrenic nerve exits the spinal column, and it's going to go down to the diaphragm and to the intercostal muscles, and it's going to stimulate this diaphragm to contract. And when the intercostal muscles are stimulated and the diaphragm is stimulated, they contract, the ribs are lifted upwards, the diaphragm pulls downwards, and this is going to enlarge that space in the thoracic cavity. Now, just before this inspiration, the pressure in these lungs is about the same as typical atmospheric pressure. But when that thoracic cavity increases in size, the potential space between the pleural, the visceral pleura and the parietal pleura becomes larger, which creates a negative pressure within the lungs. So air is going to come in because it's going to diffuse from higher atmospheric pressure to slightly lower intrapulmonary pressure. Air moves in, and then air is going to stop moving in when the intrapulmonary pressure is approximately equal to the atmospheric pressure again, which is going to complete your inspiratory cycle. At this point, a portion of the air that you inhaled has come into the alveoli and gas exchange is happening. Oxygen's going into the capillary beds, carbon dioxide's coming out of the capillary beds. Once the diaphragm and these intercostal muscles relax, the intrapleural and intrapulmonary volumes decrease, which means pressure is going to increase because of the amount of air that's in there. Now, once again, air is going to move from higher concentration to lower concentration, so you're going to exhale. Exhalation is considered to be a passive process because it doesn't require anything else to make it work. Now, one thing that the trigger for your stopping that inspiration is going to be what's called the Herring-Brewer reflex, and this is just a stretch receptor in the lungs that says, hey, we've got enough. Now, as for that secondary stimulus to breathe that we briefly mentioned, this is going to be, instead of carbon dioxide and a decreased pH being our stimulus, this is going to be decreased oxygen levels. So basically what happens is your body during, certain things will cause your body to get used to chronically higher levels of CO2, like say smoking or something like that, where you are going to have elevated levels consistently. Well, your body can't always tell when is it time to breathe and when is it not if we always have elevated levels. So eventually it's going to look for another way to tell when it needs to breathe, and it's going to look for oxygen. So when that oxygen level drops, it's going to tell us, okay, we need to breathe now. A couple other things you just need to be familiar with as far as the respiratory system. Tidal volume. We know this is the volume of air that's typically inhaled in a breath, and this is approximately 500 milliliters. Now granted, this is for an adult. We also want to remember dead space, which is approximately 150 milliliters for everybody, and that's pretty standard. So the amount of air you're actually getting in is about 350 milliliters. This is what's really important if you have somebody with shallow respirations, because let's say they're only breathing in 300 milliliters. Well, the dead space stays the same, 150, so 300 minus 150 is 150. So the difference between 350 milliliters and 150 milliliters is quite a big difference when we're looking at volume of air coming in. Now, your minute respiratory volume is just the volume that's exchanged over 1 minute. So you take your tidal volume times the respiratory rate. Vital capacity is the volume of air that's at a single maximal inspiration and expiration. That's about 4 liters. So that's like expanding your lungs as far as you can. And then residual volume is the amount of air that's going to stay in the lungs after each exhalation. And that's going to be about 1.2 liters on average.